Hello, everyone, and welcome to this episode of The Lion's Den. I'm Dr. Ashanti Carter, and I serve as the Director of Community College Partnerships of Charles R. Drew University of Medicine and Science. And today, you guys, boy, do we have a show for you. We are celebrating National Latino Heritage Month, and I am joined by our premier and esteemed CDU faculty, and that is Dr. Margarita Loeza and Dr. Roberto Vargas. So let's give them a round of applause, everybody. Yay, woo! So just so that we can just lay the groundwork and lay the framework, come on, Dr. Margarita Loeza, introduce yourself to the people.
Hi, everyone. Margarita Loeza. I'm a family medicine doctor, and I work at CDU, and I'm the Assistant Dean of Admissions and Student Affairs for the new College of Medicine. I'm born and raised in West Los Angeles. My mom and dad are from Mexico, and I'm the oldest of five.
All right, so the oldest of five, I love it. So you're like second mom there, aren't you?
I don't know if they want to know. They probably think of me more annoying than that.
I
like
know.
Tiger Mom. I would say Tiger Mom to my brothers and sisters.
I know that's right. Same here. Same here. Dr. Vargas, introduce yourself to the people.
Hello, everybody. I'm Roberto Vargas. I'm an internal medicine doctor by training, also in the College of Medicine with Dr. Loeza, where I serve as the Assistant Dean for Health Policy and Clinical Partnerships. And I also direct our Health Services Research Center at CDU. My dad is from Honduras.
All right. I love it. I love it. So let's get into the conversation. What was college like for you both? So I'm going to start with you, Dr. Loeza. What was college like for you?
It was really hard. I think I was really sheltered as a kid. I went to Catholic school, and my mom and dad really didn't let me go anywhere. And so when I went to college, I looked for a college where I could, it was mandatory at Occidental College that a freshman live in the dorms. So that was my loophole to get away from my mom and dad. And I mean, they were cool, but I wanted to leave the nest. And so college was really interesting for me because Occidental was a predominantly white institution. And I think there were 7 Latinos in the freshman class. I was the class of 1990. And so, I was the only Latina in my science classes with the one Black woman. It was different. And even though I grew up in West LA, my high school, there were a lot of Latino kids. So it was different for me at Occidental.
Were you first generation?
Yes. My mom, I am first gen. My mom and dad did not, I'm even like first gen high school student. My parents didn't go to school. My mom's family, they didn't have money. And when they did send a kid to school, it was for the men. And my dad, they had money to send him to school, but he didn't want to go. So my grandma was like, okay with that, so my parents did not receive a formal education.
Wow, but look at you, right? But look at you. I'll let that sink in with our audience, folks who are watching. Look at her, right? Dr. Vargas, talk to us. What was college like for you?
So similarly, I went to a predominantly white college in Philadelphia, but for me, it actually it was good because we had a strong minority student group there. Growing up in New York, my experiences were a lot different than some, and especially as somebody who is Black with a Latino name and a Latino father. It was a lot of times people will see you a certain way, and then it's very different in terms of what they expect when they see your name. Sometimes they'll see your name and then you show up and it's very different. But
wait, no, you can't just say that and gloss over. What do you mean by that, Dr. Vargas?
Well, yeah, I mean, as someone who's a Black Latino, in different parts of the country, when people see you and when they see your skin, they make assumptions about you. At the same time, when somebody sees your name and they don't see your face, they make assumptions about you. And so, so you'll get that. Sometimes Black people will look at me and see my name and look, and say, "What? Where you get that?" And other people may see me who are Latino or and look at me and say, "Are you really?" So, but that was never really an issue for me as much in New York, because in New York there were a lot more Black Latinos, and I never really felt that. But your question about my college experience was one in which, because it was a predominantly white institution, and because those of us who were there, both Black and Latino, were prepared to be in that situation, we had a strong collaborative sense of community. And so that, so I had that sense of community, although we were minorities there. We were vocal, and we learned how to access resources, and we worked together, the Blacks and Latinos, at University of Pennsylvania to support each other, and to actually ensure that we had resources and support. Medical school was a little bit different. It was more like Margarita's situation. I think there was 4 of us total, Blacks and Latinos combined. One guy was Puerto Rican, me and 2 other Black students, one who was Jamaican and one who was from the States, out of a medical class of 250 students. So it was 4 of us, and that one that was tough. I kind of felt like Margarita did in that science class.
Yeah, and really looking at the stats, it seems like it's still very much similar with our medical school classes and even health professions classes across the board, but we'll get there. We'll get there, since both of you work at the medical school. So both of you have the commonality of attending a PWI. For those of you in the audience, a PWI stands for a predominantly white institution. And research has shown that with BIPOC, Black, Indigenous people of color, students attending a PWI, sometimes they don't feel a sense of belonging. Can you talk to us about how you found your tribe, or, since we're CDU Mighty Lions, your pride in medical school? How did you do that? I'm going to continue with you, Dr. Vargas.
Yeah, so as I mentioned to you before, I think in college it was not as challenging because there were a larger number of us. We had 200 or so students out of a freshman class of 2,000. In medical school, it was much more challenging. And I think on the rotations as a minority physician, and as someone who when you're on those rotations, it can even be more isolating when you're at predominantly white hospitals and you're in the care of Black patients and Latino patients, and you have to, deal with protecting them in some respects from other situations where they might be treated unfairly. That's an extra burden. So those things are tough, but finding the tribe and finding people who share your vision, even if they're not, the background is helpful, because those things matter. But I think the encouraging part, and I'm going to pass the baton to Dr. Loeza, is that we have places like CDU, and having practiced in a lot of different institutions, being in a historically Black university and Hispanic serving university that embraces those values, and that from your colleagues to the leadership to the students, you don't have that feeling of being the other, makes a very big difference psychologically. And we've done, I think, great in terms of both supporting those students and recruiting them. And so Dr. Loeza, who's done an incredible job of recruiting our incoming class of students, and the diversity and the values and the sense of social consciousness and awareness that they have, has been really impressive from everything I've learned from them. And so, Margarita, I don't know if you want to weigh in more about that distinction.
About finding my tribe in medical school.
Yes, finding your tribe in medical school, because you attended my alma mater, UCSD.
Yeah, UCSD, not so diverse. I in med school, I remember in my class there was like 1 Black male and like 3 or 4 Black women, and like probably 7 Latinos or less. And what I did is I joined the Chicano Medical Student Association, which is now the Latino Medical Student Association. And I didn't just join, I was like the president, the treasurer, the secretary, the medical student, all through 4 years. And I put on the conference. And then my friend was in charge of SNMA, and she didn't have any members, so I joined SNMA also. So I was in SNMA, and LMSA, and I just concentrated on that. You know, I went to school and I just was kind of like decided, and maybe it wasn't a good thing, but I was just like, well, they're not gonna be my friends, but I have my other friends, and I would come to LA on the weekends and study with my friends who were going to UCLA med school, and you know, and I just kind of stuck to that, did those activities, and kind of kept to myself.
Yeah, you said you did the activity, so you were involved in on the life of your campus, which is so important. And look at the both of you, you're both physicians. So I'm gonna just change directions, of course. And the theme for Latino Heritage Month is Latinos driving prosperity, power, and progress in America, right? So, as physicians, can you talk to me about how that theme resonates with you as physicians? I'm going to start with you, Dr. Loeza.
The theme, I guess the theme does resonate with me, and I don't think of, you know, like being Latina as a disadvantage or oh poor us. We're like we're a powerful force in this country, and we are going to be the majority, and you know, we in 2050 it'll be us, and right now the babies born are Latino. And you know, Dr. David Hayes is doing research out of UCLA on the Latino gross national product, or the Latino GDP, and how much money we generate in the US, like $3 trillion. So I think that for me, it's like I'm very proud of being Mexican American. I'm very proud of speaking Spanish. I'm very proud of being first gen, and I don't see it as a disadvantage. I know that people treat me differently, like because of that, or think I'm not that smart, but it's I think that we're a powerful force, and I have a huge community behind me. So I think that, to me, that's what, you know, the Latino heritage means to me, or the month.
Amen. I love it. Dr. Vargas.
Yeah, I'd like to reiterate, I think a lot of what Margarita said in terms of the Latino heritage and those who of us who have Latino backgrounds not being, considered a minority depending on where you are. You know, moving from the East Coast to here in Los Angeles, and the strength and the mentors that I've had. She mentions Dr. David uh, Hayes Batista, Dr. Hector Flores. You know, these are folks who have amassed an incredible amount of knowledge and power, and have served as role models at the highest levels of both medical and academic institutions. And you know, to the extent that the community here has physicians who speak the language, who are culturally competent, who have a similar background, you know, our ability to staff, clinics and hospitals with physicians who have that cultural similarity and cultural homophily is something that I think, you know, can be demonstrated as a strength and a plus. And I think that, you know, as we look across the country, uh, just as Dr. Loeza mentioned, that is growing in a way in which that feeling of being a minority or being isolated doesn't necessarily hold. And I think if we look at some of the historic data from the public health data in particular, you know, some of the disparities that you see in other groups can sometimes be mitigated when we look at individuals who've come in and have, you know, cultural relationships and networks that can protect them. And so, you know, but some areas things are worse. And I think particularly, I think COVID-19 laid to bear a lot of the disparities that we saw that were often similar across race and ethnic groups, but worse for Blacks and Latinos in particular. And I think that, so although there are a lot of strides, we still have to be mindful of some of the disparities that are there. And those disparities were really laid bare with COVID, and in certain respects got worse for the Latino community, so that areas where people of Latino background were doing better compared to whites when COVID hit, it actually got worse. So we saw some of those things change, and so we have to stay vigilant in terms of continuing to document them and identify the modifiable causes and address them. So where work disparities, ability of having autonomy, and types of things that will drive excess exposure to social determinants, we have to stay vigilant and continue to document those modifiable factors.
And that was my next question. Because when we speak of being a person of color, being Black, being Latino, what have you, we often talk about it in deficits, right? It's a deficit, but I like what Dr. Loeza and what you stated. It's our strength, right? So we try to look at those factors that provide us with the strength to overcome and to resist. Dr. Tara J. Yasso, she talks about community cultural wealth and how communities of color, we nurture 6 forms of capital, right? Aspirational capital, familial capital, linguistic capital, navigational, and so on and so forth. So you talked about a little bit about COVID. Tell me more. Is it, with, they say when white folks catch a cold, Black and brown folks, we catch the flu. Why is it that with COVID-19, it really put out health disparities? That was the buzzword, and social determinants of health. What happened? Talk to me more about.
But I can start if you want to. And what I'll do is, in preparation, I'll share a quick slide with you that really looks at this topic in Los Angeles and this question of 2 of the themes that I was raising. Can you allow me to share?
Of course.
Okay, let me know. Can you guys see this slide?
No.
I'll try to blow it up. Okay. And so, as I mentioned to you before, this is the age-adjusted death rate in Los Angeles County for whites and Latinos in Los Angeles County. Starting here where this number on this axis are the number of deaths per 100,000. So it allows you to compare deaths between groups that may have different numbers in the population for the same event. So for every 100,000 people, for example, in 2011, the death rate for Latinos was 500 compared to 650 for whites. And so for many years, the Latino death rate in Los Angeles County was lower. So some of the things that we talk about in terms of the protective effect or things of that sort, but when we look at COVID in particular, one of the startling trends was that potentially protective effect actually didn't just go away, but it got worse. Now we were tracking this, and we were seeing this at CDU at our testing site, where we tested, over 100,000 people, and the percent positive rates in the early phases of the pandemic were much higher for our Latino community because of a lot of factors, and some of that, had to do with, the ability to work from home, the ability to, self-isolate if you're in a multi-generational house, and other, risk factors that, we're really associated with, factors of, different aspects of ability to self-isolate, and where the work patterns were. We had many seminars here at CDU with Latino pastors and with Latino community members at the early phases, asking, what can we do and what were they seeing? And the faith-based community shared with us, anecdotes that they were getting from people because of issues about immigration status that were not comfortable, going to get tested. And so there's a lot of different things that came up, and the literature has borne this out. But here in Los Angeles, we saw this to devastating effect. I think some of the benefit is that when we look at the vaccination rates, as we've done better with vaccinations, some of those disparities have come down. But even in the pre-vaccination phase, increased exposure to COVID actually made things worse in that setting. So those are some examples of why we still have to be incredibly vigilant. We have to continue to fight to ensure that people have both access to care, but to reduce the social determinants of health, and to ensure that things like workplace protections and things like awareness about vaccines and support when you do get treated or implemented.
I love it. Do you want to weigh in, Dr. Loeza?
Well, I mean, I was seeing patients. I was working at a federally qualified health center during the pandemic, and I did see, or, I had a lot of my patients die or their family members die. I mean, like literally, I would have a grid of maybe 10 in the morning, and everyone one day had a loved one that they lost. And so, I mean, we saw in Dr. Vargas' graph that before you see that being Latino seemed almost protective, like the Latino health disparity, right? Why are they healthier, right? But, my patients were poor. And really, when we looked at the CDC, the numbers, it was the people that were dying were in the lower incomes. They were in the front lines. They didn't have PPE. They didn't have access to tests. If they wanted to get a test, they had to have a doctor's note in the beginning. There was no access to telehealth. They needed Wi-Fi and a good phone for a visit. It just showed that poverty and racism are alive and well. And we just added one pandemic and it just blew it up out of proportion. And so it really is just poverty is what really killed a lot of people during COVID.
Absolutely, absolutely. Money is the great divider, right? And we live in a country where, for money, for a lot of people, it is their God. So I want to just shift the conversation a little bit more, because both of you have high-ranking positions at the College of Medicine at Charles R. Drew University of Medicine and Science. So I know I'm preaching to the preachers here, but for those in our audience who are not aware, the percentage of BIPOC physicians, it remains low. Okay, it remains low, and as compared to our population, right? And also as compared to the percentage of Black and Brown students who apply to medical school, it's quite disproportionate. So, what is it that Charles Drew is doing to diversify our field of medicine as relates to physicians? I'm going to start with you, Dr. Loeza, because you're in a key position at the College of Medicine.
I think that the key thing that we're doing is that we're probably looking at the application differently than other schools, and we're valuing certain qualities or traits, both quantitative and qualitative, differently than other schools. And I think that that's the key thing. And just like COVID, people that apply to med school, the higher their income, the more likely they are to get in. And the higher your income, the more opportunities, the more network you have, the more, you could volunteer, you could take time off, you could get study aids. So we're just looking at the application differently, and we're assigning value to certain aspects of the application higher than other schools, I think. And, and we're trying to meet the need of the area. So we're looking at a lot of different things.
Okay. Dr. Vargas?
Yes, I think, in addition to what we're doing at the undergraduate medical education level, we similarly have residency programs that we're building back at CDU. And we are similarly trying to recruit and retain and promote the training of minority physicians with a focus on Black and Latino physicians to really help support the surrounding community. Some of you may be aware, but in 2007, when the Martin Luther King Hospital closed, the university lost 17 residency programs, 250 residency slots. And so in the audience, when we say residency, that's the period of training that you have after you finish medical school, but before you're allowed to practice as an independent physician. It can be anywhere from 3 to 7 years, depending on the specialty, where you train taking care of patients under the supervision, of patients. And, the training of physicians in settings like the historic Charles Drew MLK hospital setting was one of the major contributors to the Black and Brown physician population in Los Angeles, with many of them who are here today having trained at that site. But there's something to be said also when you're training, in the community and being trained by physicians who choose to serve this community, and when we have faculty who look like and have a cultural background similar to the students, it makes a difference. So that me training here now, me practicing here now and being a dean, when I look around the room at my colleagues with Dr. Margarita Loeza, Dr. Art Gomez, who I practiced with at UCLA, for 16 years, and it was just me and Art there, and Art's Latino and me, and there were maybe 3 or 4 other Black physicians in faculty practice groups that were 1,000 people, but we have now all come here to build out our clinical training programs, to start this new medical school, to give our students leaders and mentors and faculty who have a shared experience, as well as who they can look at and identify with, and that makes a big difference. And then at the highest level, at Drew, Dr. Mohsen Bazargan, who's one of my research colleagues, has a program sponsored by the NIH, which is focusing on specifically training minority clinician investigators, and we focus on identifying those physicians in research who also come from underrepresented backgrounds, and give them the mentorship and the capacity to become physician researchers and clinician researchers, get a master's in public health from Drew, as well as specialized research training, and help support them with pilot grants and focus mentorship in this setting, to really support those researchers from those backgrounds who also want to do research in that field. So across the board, at least in terms of the medical education that you're asking us about, this is a very unique situation in the country, where you have that level of support, and we are building institutions that welcome you as a Latino or as a Black student, and so and to have the physicians here to support that and back it up, make a difference, and we really do want to pull from this community. K through 12, the pipeline program is designed for students around our community. The surrounding community of CDU is 70 to almost 80% Latino. And so to have an institution in your neighborhood where you're welcomed, where you can get the highest level of training from kindergarten, through residency and through being a faculty researcher, is rare. But it's something that I think we have to promote, and we have to let students know. And it's really a blessing to have this institution here for our community.
That's true. I get so offended when I hear people say, "Oh my goodness, Charles R. Drew University of Medicine and Science, it's the best kept secret in Los Angeles." And I'm sitting back like, I don't want to be anybody's secret. Take me out in public, please. I want to be seen out in public. So, that's the purpose of the Lion's Den, is to amplify and really just share the great work that we're doing at Charles R. Drew University of Medicine and Science. And of course, special thanks to Dr. David Carlisle, who serves as the president and CEO of CDU. And of course, thanks to you all and our esteemed faculty. And I am proud to say that I am a graduate of CDU. So I graduated with my master's in public health from the Urban Public Health Program. So, you know what, Dr. Vargas and Dr. Loeza, I hear this all the time. I want to be a doctor. I want to go to medical school. Dr. Loeza, what advice would you give to a college student who aspires to become a physician? And then I'll go to you, Dr. Vargas. Come on, Dr. Loeza, what advice would you give?
I think I would have to tell the students, because I hear this story over and over again, is to protect your GPA. And I know that sounds crazy, but don't start college and take a bunch of science classes, get a job, volunteer, and do research, and then be surprised when you're not passing, general chemistry or physics or calculus or whatever. Start slow, get those good grades in chemistry and physics and OChem and bio, so that you don't have to then go to a post-bac program to enhance your GPA. Ask for help, go to office hours, find out what programs are available at your school. Ask, just, go talk to the professor if you're having problems. Just, ask for help. And, I hear this story all the time, and I see students that struggled, that had a low GPA in the beginning, and then they ramped it up, but then they did a post-bac or a master's because they kept trying to increase their GPA to get in. But if you're a freshman or a sophomore and you're not doing well, pull back, ask for help, protect your GPA, and take it slow. You don't have to do a billion activities to be a doctor. You just have to have a solid science, get a good MCAT score, and do some volunteering. But I just would say, as many first-gen students are used to doing everything themselves and are used to not asking for help, because they're the helpers, they're the ones translating, interpreting, paying the bills, doing all the stuff. And then when they go to college, they don't know to ask anybody for help. So I think that would be my advice. Ask for help, protect your GPA.
Dr. Vargas?
Yeah, I think I can't emphasize that enough. And I think that, the best, position to be in is to be prepared. And I think the other thing is to take advantage of the resources. As we mentioned before, we have, K through 12, we have pipeline programs. Drew offers the ability to do research as a high school student. And so one of the things that I think made a very big difference for me was my high school, similar to Drew, had a summer science program. And I did that my first year, and you learn lab techniques. And then if you do it successfully, they place you in a lab and you work one-on-one with a researcher. And so for me, it was helpful in a lot of ways because it included our ability to not only have that on my application when I applied, so that in addition to your GPA and your SAT scores getting into college, you had that so you got into a better school, but it also demystified the world of science. As someone who didn't have a scientist and a physician in my family, I had now mentors and I had a relationship. I knew what science and research was about. And the discipline that it takes to do that type of project transfers over often to the discipline that's required to actually excel in your classes. And so in addition to, being focused on making sure that you're attending your classes and studying to get the GPA, having the focus and the discipline to do those things and then take advantage of the extra opportunities. And sometimes those extra opportunities are also assistance when you're struggling. So whether that's, a tutor or a mentor, and you don't want to be in that position, but if you are in that position where you haven't done well at the start, it is very important that you focus on improving. And if you're not discouraged, focus on the trajectory and not necessarily where you may be. And that will also help. So, those are things that I think helped me. And I feel that, those of us, who may be fighting other odds and other challenges can achieve and overcome some of the other things that are going to be working against us.
Yeah, it sounds like what you both are saying is to have a battle plan. When I talk to youngsters and coach them in their pursuit of having a career in medicine or healthcare professions in general, I always tell them you need to have a battle plan. Make the time. Like you said, Dr. Vargas, you have to discipline yourself. Make the time to do those MCAT passages. Make the time to go to tutoring. Don't wait until the last minute and you're on AP. For those of you who are in college, AP does not stand for advanced placement like it was in high school. It stands for academic probation. You don't want to be on AP, y'all. So, you don't want to do that while you're in college. So you want to make sure that you are on the good foot, you are on the right track. Have a battle plan. Have it, because that's what these percentages, it's crazy that 6% of physicians identify as Black. I think for Latinos it's like 7 or 6, between 5 and 7. Yeah, it's this is madness, you guys. This is madness. But I do have another question. I know we have a question in the Q&A box. Yay, you guys, keep them coming, keep them coming. But when we talked about the importance of having, doctors who are culturally competent, yeah, protecting our patients and so forth. Can you just talk to me a little bit? And this is for you, Dr. Vargas, because you're in health policy. What policies can be enacted to protect our citizens so that they, if they're seeing a doctor, they're not mistreated? Quick story. So had a family member who was really sick, like really sick. And this was when no one knew what COVID was. And this person went to the ER and, called me, oh my gosh, they sent me home. And I could hear them like trying to catch their breath. And I said, what happened? Oh, well, the doctor, who did not look like this person, said, yeah, I was just stressed out, and they sent me home. I was just stressed out, and they wouldn't even listen to me. And we hear these stories all the time of Black and brown folks being sent home with an aspirin, and the next thing you know, they're dead or something tragic has happened. What protections should be enacted, Dr. Vargas, to protect our people?
Yeah, so I think, when we think about health policy, specifically as it pertains to racial and ethnic disparities, the history of documenting differences by racial and ethnic group really starts back in 1985. And really through that time period was a matter of researchers trying to demonstrate these disparities that you talk about. By the time that I was, finishing medical school in the 90s, we started to know about that a little bit. And then the literature started to say, well, it's not just because, people who are Latino or Black, don't have as much insurance as others, or because they are, have health behaviors that are different that are causing these deaths. We were beginning to really disaggregate these disparities in a way that I think was really, really informative in terms of action. And so that by the time we get to the 2000s, and we really have a really strong body of literature, we get to that point where you have about 15 years of literature showing that there are other causes and that these causes are modifiable. That was really helpful. I think one of the earliest policies to address this was the Culturally and Linguistically Appropriate Services Act in the 2000. And what that basically said was that if you were going to get federal funds to care for a patient, you had to provide services for them, culturally and linguistically appropriate services. That really moved healthcare providers to now say, if you're going to take care of Latino patients who don't speak English or have Spanish as their first language, you're going to have services available for them. And so, as opposed to just pulling someone from their other work to translate for you, offices had to get translation services on the phone. Offices had to really consider who they're going to hire and bring folks in to do this, and it became a law. So that's an example of a policy that started in 2000 that was really focused on trying to ensure that we had culturally appropriate services to balance out some of the disparities that we saw in terms of how people feel and who gives them care. As we move on, some of these other things like the disproportionate amount of people who are Black, Latino, who are immigrants that don't have insurance. The Affordable Care Act was another, I think, watershed in terms of making healthcare available to those who historically couldn't afford it. And when we look at Los Angeles County, for example, historically there was something called My Health LA and Healthy We LA that afforded health coverage for people who did not have, that were undocumented. And so if we had folks who were from backgrounds where they were immigrant families and they were undocumented and couldn't qualify for Medicaid, now that's going to be changing this year. But so there are policy things that we can do that we have to lobby for to ensure that, those of us who, because of language, because of, documentation issues, might not be able to get, the standard of basic care that should be a right here, we get. And so I think moving forward, the next set of policies we really have to think about, and I think we'll see soon, is to really look at things like implicit attitude testing. And so this
Mm.
now gets into providers and those who are overseeing resources and the decision-making roles of caring for people to really assess themselves for their bias. And really what this comes down to is racism. And I think, I would say that when we started looking at implicit bias testing, because anybody can have those biases, and for the audience, it's a way where you get a series of pictures very fast, and you click whether you like it or you don't. And because they really get to your unconscious response, it begins to disaggregate people who may have biases against people who look brown or black. And when researchers started to use this, they found very surprising results, or maybe not surprising to some, that some of the highest professions had very high levels of bias against Black and Latino people. And so people who might have not even considered themselves racist. And I think that was getting a lot of buzz because people were fearful of it. But unfortunately, I think the worst thing about maybe the past 6 years or so is that we now have leadership at the highest levels who are openly embracing racist policies, racist people, and are just overtly racist. And so the resurgence of overt racism, I think, has highlighted the fact that there are people who are in power and who control the people's lives that are racist and therefore are going to make decisions when you're treating people and when you're allocating resources, influence on those biases. And it's sad, but it was something that I used to really think, okay, we have to do these implicit tests so that people know this is real. And now a lot of people in leadership positions don't even care anymore. So we still have a very long way to go in that battle. But there are policies that I think have made a difference.
Thank you. Thank you for that, Dr. Vargas. Dr. Loeza, you want to weigh in?
You have to ask me the question again.
Oh, yeah, no, not a problem. So just looking at health policy, and we've talked about the importance of developing physicians of color to care for our communities because oftentimes we aren't listened to.
Right.
What policies can we enact to make sure that patients of color are listened to and they receive the superior care that they deserve?
I think the important things Dr. Vargas talked about were access. And when I was working at a community clinic, when I first started, like 80% of the people didn't have insurance. And then we got the ACA, the Affordable Care Act, or Obamacare, and then it was like Christmas for me. I was like, yeah, everybody had insurance, super happy. We still had My Health LA patients who were undocumented, but we had people now had Medi-Cal. And then Medi-Cal expanded to more bigger age group of undocumented people. So just having policies in California where people have access to care or insurance, and really My Health LA is only for LA County because I trained in San Bernardino County and we didn't have that. So that helps. Simple things like requiring medication to be like in the language, written in the label in the language the person speaks, or requiring that we use interpreter or translator services, or even things like having the staff speak Spanish, even if the doctor doesn't, right? And so I think all those policies and things have helped, and I did see it slowly change over time. And if I think about the conversation we're having now, we couldn't have had this conversation when I started med school. If we were talking like this, they would have been like, you guys are crazy. You don't know what you're talking about. It's like the gaslighting, right? When we would complain about things. So I think that all those policies are important. And I literally saw how different laws and different policies affected how I cared for my patients because I worked in a clinic for poor people, for homeless people. And so it's really important that we understand as doctors, sometimes we just want to do the medicine. We just want to treat the patient. We don't want to talk about politics. We don't want to pay attention. It's just, like one more thing, but it really interferes on how we treat the patient, especially like now when they're, trying to ban abortions. So it's very similar. So public policy is really important. And I know that the students at CBU are going to get a lot of that. So that's good.
That's great. And that also ties into my next question. Just looking at the lessons that we've learned from COVID-19 and how even it impacted how we teach, it impacted our education system. You know, with the scoutist position of gutting affirmative action. You said it at the beginning, Dr. Loeza, that with Latinos, the population is growing, it's booming.
Mhm.
How can we, if we cannot enact policy, how can we in turn innovate our medical education curriculum to ensure that doctors who are being trained, all doctors, Black, brown, white, whomever, they're trained to be able to treat all people with the level of respect that they deserve?
I think that like I mean, I can really only speak for what I see now in the College of Medicine, is that the physicians that work there and come and teach our students have humility and humbleness, and have experienced in their lifetime medical racism or many of the isms, and are truly there to teach the students a different way. And so I think that for a long time, the practice of medicine and the knowledge base is huge, you know, really important knowledge on how to save someone's life was just passed down from one group to another. And so it was passed down to us, but they gave it to us in a way that we didn't really like how we got it. And so now we're passing it down to others in the right way, I think, or in with our spin. I think that we're repackaging it, and this is the way it should be. And I think, like Dr. Boyce, when I see her clinical cases, she's really careful in the way that she presents things. I see Dr. Gomez, the way he talks to the students, and Dean Deborah and Dr. Ofole, like everyone, like these are all people of color who have really have seen over the years what medicine can do, and are very intentional in the way that they practice it and teach it to the students. So it's just humbleness, I think, and pride
Yes.
in your art, or your study, or your craft, or whatever we want to call medicine.
Yeah, your craft. Yes, your craft, your gift. I love it. I love it. Thank you, Dr. Loeza. Dr. Vargas, you want to weigh in?
Yeah, I think this is about, in terms of the educational environment, uh, and I think that, as Dr. Loaiza mentioned, the team that's been put together here for medical education, um, I don't think I've ever seen more highly qualified and densely diverse group of colleagues. And so it's been really an honor to build this program out. But one of the things that she mentioned was the intentionality in the curriculum as well. So, I just spent this morning teaching in what's called the Medicine and Society course, where all of our students go through, as first-year medical students, training in how to interview, but also how to look at a specific question. Last week we did adverse childhood events. The last session this morning we did breast cancer screening and diagnosis, and talking to a patient about risk. But doing that in this context of the individual, potential disparities, and then looking at health system disparities and how patients of different backgrounds, either race, ethnicity, language, perceive risk differently, and how we have to communicate that. And looking at how health disparities that are clear in breast cancer outcomes are related to the fact that people aren't getting services, both preventive and treatment, equally. And what are some of the drivers of that? And having, our students have that in the forefront of their mind while they're concurrently, learning, the fundamentals. And I have to say they've done great on their first round of tests. But we reinforce that they have to actually know the science, so that when they're there taking care of their patients, they will know the right thing to do. And so when we talked about these cases, we were getting examples, because one of my students was an interpreter at a clinic, and another one was a medical scribe. And as young minorities, non-clinicians, they were in the room where they saw patients being treated unfairly. They, as a scribe, scribed something that the physician said, in terms of a patient being, having someone have a procedure explained to them that they clearly didn't. And they were instructed to kind of check off this box. And this patient did not have good English. And the student clearly saw that this person, didn't have this, and questioned that, and questioned, the other physicians about, how to handle that. So, but you have to know the right thing so that when you get to those levels and you're in those rooms, you can, see those. So it's a balance. So we have to do both. We have to make sure that they're prepared at the highest level, as Dr. Loeza said. You guys have to have those grades, protect their GPA, study hard and be disciplined, because you have to be able to protect folks, and you have to have that knowledge. But you also have to have the humility and the wherewithal to protect people when you see things that are not being done appropriately. So it's balance.
Yeah.
It's tough. It's tougher for us, but I think people have the adage, to whom much is given, much is required. And if it ain't for you, that's fine. But I'm surrounded by colleagues who've stepped up, and we're recruiting and identifying people who want to be leaders for change.
That's what I'm talking about. CDU is all about developing champions for health equity. I love it. So time is upon us. I could talk to you guys forever because both of you are amazing. So we do have a question. Hello, Dr. Loeza and Dr. Vargas. Thank you for hosting this informative webinar. What do you envision community health outcomes would look like in SPA 6, so Service Planning Area 6, that's in the community of Watts in South Los Angeles, 100 years from now? Thank you for your question. Wait, but 100 years from now, those people are going to be gone, because for the person who asked that, change is coming, and I see it. Yes, indeed, gentrification. But go ahead, Dr. Vargas and Dr. Loeza.
You want to take that one first, Margarita?
I always have like a dark thought every time I'm at Drew. I'm like, this neighborhood's going to get gentrified. They're going to take it from the community. And I don't know if it's just like, gloom and doom, but I'm like, they're going to see the med school, the hospital, and they're going to buy things up, and they're going to push people out. Like, I keep getting scared that that's going to happen. Right. And that we'll have to move the school and the hospital to another area. I'm like, the dark side of me thinks that. I'm hoping that's not true, and that people will still be able to live and afford. But I think it's the reason I think that is because I grew up in West LA, and every time I tell people I grew up in West LA, they thought I grew up super rich. But West LA used to be a lot of Latino people. I lived in 2 houses in West LA. They were both, knocked down, and almost all my friends moved east, and to East LA, or Downey, Cudahy, around there. And so I feel like the same thing's going to happen there. I feel like it's going to get gentrified, like my neighborhood got gentrified. And like, the big important thing to me when I bought a house is to buy a house in the area where I was pushed out of. So I was like, I'm back, and so, and they're like one of the only Latinas on the block. My brother and I were gardening, and they came by and they asked us how much we charged to garden. And my brother was so mad. And I was like, why'd you scare him away? We could have had a side hustle. And, he was just like, he was so mad. But I know why he was mad, and I was just teasing him. But I'm afraid that it's going to get gentrified. I hope it doesn't. But that's what I fear. But I won't be here in 100 years to see that.
Yeah, I'm not. I try to be. I think in my heart, I see where Dr. Loeza is coming from, and I try to be more proactively positive, because I'm a realist, but I am also an optimist. And so 100 years from now, we'll have the 100th anniversary of this new medical school. The inaugural class that Dr. Loeza has brought in. Yeah, we'll be gone, and they may be gone too, but we will have trained physicians who have trained other physicians. who I think will be providing the highest level of care with the highest consideration for cultural competency and from backgrounds that will be similar to people to them. And as an optimist, I'm going to hope that South LA doesn't get gentrified. We have Watts Rising. We have the Housing Authority of Los Angeles. We have our colleagues in the College of Science and Health who are doing research and are part of collaborative efforts to help people in the community maintain their homes and not get displaced. And so, there's activism that is fighting against the things that Dr. Loeza talked about. The reality is that there's, forces that are going to be going against that, but we're trying. So I'm going to stay optimistic and say things will look similar, and that the biggest issue is that the death from preventable and treatable diseases, that gap will narrow, and that the persistence and the long-term persistence of equal health insurance, the growth of providers that people feel comfortable with, the strengthening of the institutions around the community. We have 8, hospitals now that have agreed, to train our students, and getting our students in those places will hopefully have people access care earlier and not be as subject to some of these challenges like housing. So I'm going to be optimistic and say 100 years from now, disparities will be gone, but or at least less. Okay, I see the cynicism there, but it's because this is not a new battle.
I'll come back.
We've been at this for hundreds of years, hundreds of years of between colonization, slavery, displacement. This is not new, but I think progress has been made, and I'm going to stay positive that we're going to keep going in the right direction.
Okay, thank you. So as we end, you guys talked about, the cultural competence and really just meeting the patients where they are. So in our minute that we have left, I am going to plug See the City You Serve, which was actually founded by the Rodham Institute, Dr. Gigi El-Bayoumi, who was the founding director at the George Washington University School of Medicine and Health Sciences. So I am bringing it here to Charles R. Drew University, and we will be taking a bus tour from SPA 6 over to West LA of SPA 5, and we are going to compare and contrast the various healthcare systems and the infrastructures that are there, and really just tie it back to the role that CDU plays in the life of our community. So sign up. We will provide you with a free breakfast and lunch. Bring your students, bring that knowledge, and I look forward to seeing you. So Dr. Margarita Loeza, thank you for coming into the Lion's Den. Dr. Roberto Vargas, thank you for coming into the Lion's Den. I told you this was going to be a great conversation. And thank you all for being here with us and learning. And I look forward to seeing you soon. All right. Bye, everybody.